echo is the most sensitive and definitive diagnostic tool to diagnose atrial septal defect. On echocardiography, you have to go retrospectively. You look for the whenever there is a dilatation of RARB, you look for the causes of RARB dilatation. So for practical purpose, when there is dilatation of RARB, you have to look for three causes. One, as we are discussing, atrial septal defect can cause RARB dilatation because in ASD, this blood is flowing from the left atrium to right atrium and right atrium to the right ventricle. So there is increased flow to RA and RB. That's why there is increased size of RA and RB. And then we will expect the increased pulmonary flow. So the pulmonary velocity might be on the higher side. Since there is increased flow to the pulmonary circulation, there is TR, tricuspid regurgitation, and there is increased pulmonary artery systolic pressure. If they are more than 35, then you say the pulmonary arterial hypertension. You might have the dilated IVC because of the pulmonary congestion. Then you will see the atrial septal defect. You can see the anatomical defect, but apical four-chamber view is not a very standard view to see the atrial septal defect because there could be a lot of acoustic window which is obstructing the view of interatrial septal, and even in the normal patient you might see the defect in the interatrial septum. Subcostal window is the most commonly used window to identify the interatrial septal defect. We were discussing the causes of RA-RB dilatation. ASD is one cause for RA-RB dilatation. Another important cause is pulmonary embolism. Again, pulmonary embolism is an emergency. If patient is having RA-RB dilatation because of the pulmonary embolism, the patient must be very symptomatic. He must be having hypoxia, shortness of breath. There might be tachycardia or hypotension. Patient might be having dizziness. It is unlikely that patient is having RA-RB dilatation because of pulmonary embolism and he is completely asymptomatic. His saturation is 100%. He is not tachycardic. Unless there is a old pulmonary embolism, still you will find some symptoms. Then another emergency which can cause RA-RB dilatation is acute inferior wall MI. Because of the RB involvement in inferior wall MI, it can also cause RA-RB dilatation. The treatment is different, completely different in all three. So that's why you have to think about all three reasons before you manage the patient. There are some associated defects which are common with the ASDs: mitral valve prolapse, bicuspid aortic valve, ASD and BSD both. When they both are present together, ASD and BSD, basically there is a common defect which is called AV canal defect. AV canal is atrioventricular canal. So basically there is whole defect in the interatrial septum, interventricular septum, which are close to each other. So the inferior portion of the interatrial septum is ostium primum, and the superior portion of the interventricular septum is membranous parts. So there is a membranous VSD and there is a primum kind of interatrial septal defect. So when both are together, this is called the AV canal defect. So what are the indications for intervention in ASD? If patient is having symptom and symptoms are because of the ASD, when there is a significant pulmonary blood flow that is more than 1.5:1, when there is increased pulmonary artery systolic pressure, which you can measure on the echocardiogram, when there is a RA-RB dilatation because of the ASD, when there is a systemic embolism, that means there is a patient is having a stroke, and that stroke we can expect from the ASD or PFO. So there are two ways of treatment, that is device versus surgery. Device, when we do the device, when there is a good margins, that means there is, you are doing an echo study and there is a rim present which can handle the device. If there is no good margin present for the device, you put the device and it will dislodge from the original position. It might go into LA, LV or aorta. So there has to be good margins to fix that device, which is called, it's like a umbrella like a device which you take into the interatrial septal defect. You open it like an umbrella and fit it into the defect, and it closes the defect. So when there is good margins present on, which is can be done by the echocardiogram, and when you are doing the echo, the cable margins, there are few margins. There's aortic margins, there is IBC margins, there is SBC margins. So out of these margins, especially the SBC margins and IBC margins, they are the important. Aortic margins are not that important. If the size is very large, that's more than 35 mm, then it is difficult to fit the device. If there is associated defect like mitral valve prolapse, which is requiring surgery, then obviously you can go for the surgery. So primum and cable defects, these are the defects which don't have any margins and they need to be repaired by this surgery. Only the ostium secundum defects generally have the good margins and they can be treated with the device.